the South Delhi branch to have called me here. I continue actually, Madam just said no, it's a different thing coming all together, but I continue because I get my patients from them only. Most of the deafness what we treat is congenital, and toxoplasma, rubella, consanguinity in our country where marriages are between close relations, connection 26, is the cause of deafness. It is rampant in our country and the third world countries. Actually in the developed countries, this has become obsolete already, and that's why they've started doing other techniques for cochlear implantation, but we still have a long way to go. Dr. Chanchal just said I have done 1,000, but for every 100 patients I see, I do only one cochlear implant because of the paucity of money which is there, and the device is very costly. So today I'll be talking about three things. One, what is an indication for cochlear implant? Who is a candidate for cochlear implant surgery? The minimal invasive technique which I started in this country 15 years back, and why is it advantageous than the other ones? And last but not the least, how nicely you can do, and why not many surgeons have been able to pioneer these, because we have to be correct millimeters by millimeters. Cochlea is a tonotopic structure. Dr. Chanchal just said that we are not only giving one physiological thing, we are giving actually two. If the child hears, he also speaks. So by one implant, we are doing two benefits to the child, and that's one of the most important things to do. Cochlear implant per se has two parts. One, the inner device which we as surgeons implant. The outer one, which has the microphone and the battery, picks up the sound. It then through radio frequencies gives it to the inside implant, which converts it into bioelectrical current, because that's what the dendrites and the spiral ganglions and the nerves understand. They won't understand the sound. So that's important, and that's where the cochlear implant differs from what a hearing aid is. Hearing aid only amplifies the sound and gives it to the hair cells in the cochlea, which then transform them into the bioelectrical current, and which is then given to the nerve, because it then goes to the brain, goes to the center where it is decoded. We understand what we have heard. Then the impulses go to the Broca's area, that is the speech area, and we start to speak what we have heard and understand. So that's all about. As a surgeon, my thing is to put this device beautifully inside, millimeters by millimeters, so that it represents the tonotopic structure of the basilar membrane, stimulating the higher frequencies where it should be stimulated and the lower frequencies where it should be. So the ENT surgeon today was being eluded by this spiral structure called the cochlea and the nerve. So now we do the cochlear implants, but ours is a fifth center in the world which also does the brainstem implant. So if you don't have the cochlea or you don't have the auditory nerve, then we put the electrode inside the fourth ventricle where the auditory nuclei are there. So this is the fifth center, and we have done more than 10 cases, small children. So I'll tell you why early detection of hearing loss is important. We can actually detect a child how much he is hearing inside the mother's womb after the 7th month, and that is when he hears the mother see. But it is not useful because we don't want to tell the mother that the child is not hearing for those 2 months till such time it comes out. So at the first day of life, we can actually pinpoint how much is the hearing loss and to what extent in each frequency the hearing loss is there, and that makes the diagnostic tool so beautiful that we can, on the first day of the child's birth, we can say that this child has a problem and he needs to be addressed as soon as possible. I would also like to say why this is important, why to do it so early, because of brain plasticity. If a child doesn't suck the mother's breast for the first 1 week or 10 days, he forgets to do that. So God has given us something in the brain by which we can do certain things. A calf of a cattle will just stand up and start running, where a pup of a tiger and the child of a human being cannot do that. So this is all about neural plasticity. So we have to take advantage of this neural plasticity, stimulate the centers of the brain at its earliest, and do the technique at the relevant time. There are about 4 implants available in this world, and I'm the only surgeon who does all the 4 implant systems. And we also now do the auditory brainstem implant. You can see the electrode going inside the foramen of Luschka, where it stimulates the auditory nuclei. Now, before we really come, so this was just to tell you how important it is to select the right candidate. So if we don't do that, we were talking about all these MIS surgeries. It is the selection of the candidate which is very important. If we don't do it properly, we are gonna get bad results. And if we get one bad result, many more implant surgeons, patient children would not get an implant because they go and see. This is a very close-knit family where one child goes and sees the other one, how the child is doing, and what are the results. Only then they come and spend so much of money. So the most important thing is that the inappropriate patients should not be implanted so that the results are not so bad and every child has some good results. But I'll tell you that at different stages of deafness, the results would be different, and that's what you have to explain to these parents, that get it done early. We are now operating at 9 months as far as the cochlear implant is concerned, and we operate brainstem implants between 1 to 3 years of age, because that is the time. We can't do that before 1 year because the brainstem is not well developed. We can't do it beyond 3 years because by the time the Broca's area and the auditory center is completely gone, as far as the brainstem implant is concerned. But as far as cochlear implant is concerned, that can be done at later ages, and I'll show you certain results how to start doing after cochlear implantation. Audiological, I won't go into the detail, but this is what it is. We have to do audiology to its maximum so that we know what is the residual hearing, and if there is residual hearing, the results would be better. Earlier we used to say it is the stone deafness which should be operated, but now we say no. If there is some residual hearing, that means the auditory pathway is still intact. The center in the brain knows what it is hearing and what it has to do after it starts hearing normally. So that is important. So audiology would tell us what exactly, and from 1985 till today, things have changed. Now we do electroacoustic stimulation. That means you do an implant and give a hearing aid in the same year. So if you have some residual hearing in the lower frequencies, you give a hearing aid for that. And for the profound deafness, you give a cochlear implant. So you have to put electrodes so nicely that you don't kill this residual hearing inside the cochlea, and the apical frequencies remain intact and do very well as far as electroacoustic stimulation are concerned. So we have now come from a stone deaf child to an electroacoustic stimulation surgery, which is a great thing. I won't again go into the details, but yes, in an adult you can get a pure tone audiometry and an 80 audiogram. A speech discrimination score is important. Now some say he is hearing. It is like giving half a chapati to a person who actually needs 4 chapatis a day. So if you give just a hearing aid and the child is not doing well, he is not understanding speech, actually you are not benefiting the child. So in this, if an adult who is given 100 sounds or words, and he understands only about 30 or 40 of that, he is a good speech. So in that we do the otoacoustic emissions, the BERA, ASSR, and all these things. So we have a battery of tests in which adults and children can be identified properly, and I won't go into the details of all this, I've just told you. Now coming to the profile of hearing loss, this is very important. You have to be sure that the problem is in the cochlea, the transducer system of the cochlea. And if we are not sure that the brain center, for example in encephalopathy or cerebral palsy or other situations where there is trauma to the area of hearing and speech, and if you give a cochlear implant, the child would not do good. So you have to be sure that this is peripheral deafness and not central deafness. Central deafness is the only situation which I told you in which the centers of in the cortex and the temporal bone are not working properly, that the child would not understand. He would hear but not understand what is being spoken, and that's why he would not develop speech. So it has to be peripheral, and peripheral means cochlea, the nerve, and the auditory nuclei. Beyond that, we have the medial geniculate body, the inferior colliculus, and then the higher centers in which, if there is a problem there, it becomes central deafness, and that at the moment we have not been able to really treat. So this is the only the grey area in the, when I say deafness, no more, or disability. But I think, as Dr. Rahul Manchanda was saying, this is magic, and you never know what level of magic we can go in for. Etiology is also important because children with ototoxicity would do much better, or with the otodystrophies like Paget's disease and autosclerosis would do much better than people who have meningitis leading to a neuropathy of the auditory nerve. So, or even presbyacusis. If an aging person has more of neural loss, then it will be a problem. But I must tell you that the cochlear implant needs only 10% of the auditory neurons to transmit sound from the cochlea to the brain. And so even if in presbyacusis, these adults are doing very well, because you don't need all the auditory neurons to be stimulated in cases of cochlear implant. So etiology is very important. Yes, if you have meningitis and an ossified cochlea, you can't do a cochlear implant, you have to go in for an auditory brainstem implant, and the results would be extremely well, because the child in this case had heard, the center was stimulated, and so he would do much better than a person who has never heard in his life again. Duration of deafness is again very important. If the duration is small, if I become deaf tomorrow and I'm implanted within 6 months, I would do extremely well. But if I take about 25 years to do the surgery, if I don't have money or maybe the resources, everything, and then the center becomes a little dormant, it has to be revived again, it has to be stimulated again to come back to the normal situation. It's like you swam when you were small, and now you are 60 and you're trying to swim again. You will have to maybe put in a little effort to do that, but you will be able to do. So मैं एक छोटा सा एग्जाम्पल देता हूँ अपने पेरेंट्स बच्चों को इसमें, जो कि मैं आपको बताना चाहूँगा कि एक हिरन का बच्चा पैदा होता है, उसको ऊपर वाले ने बताया कि वो उठते ही भागेगा. अब आप दो सिचुएशंस क्रिएट करिए. एक में उसके पैदा होते ही पाँव बांध दीजिए, फिर एक दिन बाद, एक हफ्ते बाद और एक महीने बाद खोलिए. एक दिन बाद वो थोड़ा लड़खड़ाता है, उठ के भाग जाता है. एक हफ्ते बाद थोड़ा ज्यादा लड़खड़ाता है, लेकिन तब भी भाग जाता है. एक हफ्ते बाद नहीं चल सकता. दिस इज व्हाट इज कॉल्ड न्यूरल प्लास्टिसिटी. एक और हिरन का बच्चा पैदा हुआ जो थोड़ी देर उठकर भागा, फिर आपने उसके पाँव बांधे. ये एक महीने बाद भी अगर हम इम्प्लांट करेंगे या उसको समझाएंगे तो कर सकेगा. So this is because the center now knows what to do, and you just have to revive that situation that the center starts doing again. So that is what duration is all about. And when I say this, I also emphasize on the fact that if the child is not able to do a cochlear implant for many reasons, financial and otherwise, please give a hearing aid to this child. So that is for the ENT surgeons, but otherwise also, if you come across a child who is deaf, not hearing a hearing aid, that means the auditory pathway is getting plastic. So whenever you do a cochlear implant, even later on, this child would take a long time. And now we have PET scanning which proves that the auditory center is taken over by the visual center. So it is actually, once you give a cochlear implant, you have to first take away the visual center from the auditory center and then teach the auditory center to hear. So it becomes all the more difficult. So when you are giving a hearing aid to this child, the child would keep on hearing and the center would remain auditory and not become visual. So that is what duration is all about. And I'm not going into the details of, I'll just show you a certain results.
Shriya Manu Lakshe Bhuva.
Now this child was about 12 months old and now she's 2 years and she's speaking very well. Again, if we do it early, the next child I'm showing you, we did it at 2 years and now she's 13 years. So you can see the speech is absolutely normal if we do it early. But yes, if we don't do it early,
आपके घर पे कौन-कौन है?
मम्मी, पापा, प्रिया और प्रीति है.
प्रिया और प्रीति आपकी कौन है?
मेरी सिस्टर.
so you can see that here he hears well, but just because the Broca's area has become plastic, even before the hearing area, his speech would not become better than this. But yes, if you had given this child a hearing aid, he would have done this way.
मशीन से और इम्प्लांट में सुनने में क्या फर्क लगता है?
मशीन में और इम्प्लांट में क्या फर्क है? मशीन में जितनी आवाज़ कम आती है और मशीन में फोन में मोबाइल में आवाज़ नहीं आती, बातें बिल्कुल भी नहीं आती मशीन में। और इम्प्लांट में बारिश की, मोटर की, ट्रैफिक की तरफ आवाज़ आती है, म्यूजिक की भी आवाज़ आती है, बिल्कुल सही प्रॉपर सुनते हैं। अब आप पीछे से बात कर रही है, हम बिल्कुल सही सुन रहे हैं, आप देख लेना इम्प्लांट का पार है, मशीन का पार नहीं है।
Now, if you delay it further, there is still some hope, but yes, it is not as good as cases I've shown you. She was 6 when she became deaf, and we operated when she was 27. So we actually told her that she will only hear, but we were actually surprised to see that the speech came out. So it was probably fossilized. The center Broca's area was probably fossilized at age 6, and then when we started giving the stimulus, it got revived again, and some amount of speech came back, and this was a pretty good surprise for us. But yes, cochlear implants are actually meant for these who can talk also on the telephone. Now you won't believe that this is a cochlear implanted patient. She was postlingual and now she's speaking on the telephone. So this is the kind of magic which Dr. Manchanda was talking about and Dr. Chanchal was just saying. We've really had magic as far as cochlear implants are concerned, and when I started it 15 years back, even I was not sure we would come to this level. Radiology, I won't go into the details, but we have to have CT, MRI both, because the membranous cochlea forms from the ectoderm, the mesoderm, otic capsule forms from that. So we have to have CT, MRI, which tells us there are other abnormalities. This is more of a surgeon's. We are doing normal cochleas, Mondini deformities, single cavity, but we don't do aplasias where we have to do auditory brainstem implants now. And again, if it is ossified, we have to do brainstem implants, but otherwise all other situations we can do. Medical, there is no age limit. We have done at the age of 89, and now there is a gentleman which is coming from Srinagar at the age of 95. That will be the eldest we'll do. He is almost ready, so no problem as far as health is concerned. I have Dr. Pradeep there who does, thank you very much sir to giving anesthesia to all of them. Balance, yes, there is no contraindication, particularly if it is cochlear in nature. Meniere's disease, profound deafness with Meniere's disease, it actually becomes better. Both balance and tinnitus goes away because you are destroying the cochlea after putting the long electrode inside. You are giving hearing, but you are taking away the labyrinthine and the vestibular part, so balance and tinnitus would become better. Additional disabilities. Initially, we never used to do cochlear implants in cases of cerebral palsy, encephalopathies, and mentally retarded children. But then we realized that instead of having two handicaps, if the child has one handicap, is much better. But yes, we have to do a PET scan to see whether the centers in the brain, the hearing center and the brain, the speech centers are good. The child would have a little dysarthric speech, but he would hear and speak also. They're doing very good. Psychosocial are again very important. The parents don't accept the problem, and that's why they delay, which is to be taught to them. So any cochlear implant would give us auditory perception, speech recognition, and then speech formation if done at the right time. But the more we delay, we actually try to hamper speech formation at the earliest. I've done more than 1,000. This is the all centers in the world and in the SAARC countries where now my students are, so it feels very happy. Whenever I go out, I do like CAM surgery, 18 surgeries in 2 days, because this technique which I'm talking, and this is the kind of happiness you get standing amongst the children. You can see the surgeon almost on the 11th word. This is the minimal invasive surgery. This is what Dr. Chanchal Pal was talking about. I don't do the mastoidectomy. I just create a tunnel 1.6 millimeters in diameter through which we put the electrode inside. So this is vis-a-vis the big mastoid cavity, and it looks like this. The electrode goes through and we don't hamper what God created, the mastoid air cell system, because in a 9 months old, if you take away the mastoid air cell system, you are actually trying to put the infection from the station tube into the middle ear and into the mastoid ear cell system, where the electrode would get affected and the implant would be rejected if there is infection. Thank you very much.
Thank you, sir.